right, good morning. Happy Friday, everyone. Welcome to another edition of PT on Ice Daily Show. My name is Jason London. I am faculty and developed rehabilitation of the injured runner as well as rehabilitation of the injured cyclist. And I am back in the basement today after being out for a while for these Ice Daily shows. And what I wanted to talk about today was quadriceps tendinopathy. We've transitioned back into winter out here in Bozeman. We did have a nice 1 week of fall last week, but we're back in winter. And quadriceps tendinopathy is much less common, a much less common cause of anterior knee pain than, say, patellofemoral pain syndrome or patellar tendinitis or tendinosis. But if I do see quadriceps tendinopathy in an endurance population, it tends to be in the winter, particularly in cyclists if I see it at all. However, in recent years, I've seen many more cases of quadriceps tendinopathy as we've seen orthopedic surgeons now using the quadriceps tendon as an autograft for ACL reconstructions. And we'll get back to that here in a few minutes. But quadriceps tendinopathy, like most other tendinopathies, is usually the result of a training error where there's been a very rapid increase in load in training volume, whether it be lifting, in a jumping sport, or in cycling. And that load exceeds the capacity of the tissue, and the tendon becomes injured, and then comes into this tendinopathy or tendinosis, where you can get this degeneration of the tendon. And quadriceps tendinopathy, of course, is distinct from patellar tendinopathy because it's a distinct structure. So the quadriceps tendon is different from the patellar tendon in the fact that it is connecting muscle to bone, where the patellar tendon is connecting bone to bone. So because of that, the mechanical nature or properties of the quadriceps tendon are different in that you have a difference in stiffness from the tendon transitioning from where it's attaching to muscle to where it's attaching to bone, whereas with the patellar tendon you have pretty much a uniform stiffness in the tendon between its attachment sites as well as in the mid tendon. And we have more layers of tissue in the quadriceps tendon versus the patellar tendon. So these unique properties and also being a unique structure mean that we're going to treat it differently than a patellar tendinopathy. So with all tendinopathies, quadriceps tendinopathy is no exception. It's going to respond very well to a progressive loading schedule with using a pain monitoring model to help guide if the load is appropriate to get the stimulus that we want, as well as using something like the modified Borg scale to let us know if we're getting, again, enough stimulus to the tendon. So for example, doing loaded squats, trying to target the tendon, get some irritation there where the patient is getting a 3 to 4 out of 10 on the pain scale, and getting a 7 to 8 on the RPE scale in terms of the amount of work that's going at the tendon or in the quadriceps to be appropriate load, and then having that load be on a daily basis to treat that. There's a great editorial in JOSPT, I think it was this past September, by Karen Sibonagel. I will try to post that below here sometime this morning. That really, does a good job of distinguishing quadriceps tendinopathy versus patellar tendinopathy. And when we're thinking about loading the quadriceps tendon is going to be loaded more in deeper angles of knee flexion than the patellar tendon. So when we think about doing our progressive loading schedule, maybe starting with quadriceps isometrics, progressing to either double limb or single limb squats, is instead of looking at increasing load through adding weight right away, we're going to increase load by adding progressively increased knee flexion. So with our quadriceps isometrics, starting with maybe around 90 degrees of knee flexion and then progressing to 120 degrees knee flexion. And then same thing with our squats, having the patient do their squats to a depth to where they're getting that 3 to 4 out of 10 pain, not really going above that. And then as that gets better over time, usually over just a few sessions, we can have them progressively increasing their depth before then adding weight. And I found that to be really useful in terms of getting better outcomes with using a loading program for quadriceps tendinopathy than just doing your standard patellar tendinopathy, particularly if mid-substance. What most people will use is doing those decline squats, single leg squats, and then adding load. And so, as I mentioned, with quadriceps tendinopathy and endurance population, I tend to see it in the winter. I really haven't seen anything in the literature to support why you see increased frequency in the winter. With it being cold, perhaps just not getting good enough a warm up, or something to do with vasoconstriction. I'm not sure there, but with the one population, I do see it now a lot more frequently with our ACL reconstructions that have had that quadriceps tendon or a portion of the quadriceps tendon used as an autograft. So look out for that, and making sure that when we are getting into our quadriceps strengthening with those patients, that we're not overloading the quad tendon, and that we do need to really make sure we're getting good flexibility of the quadriceps muscles restored before really getting into a lot of closed chain strengthening. And then with our closed chain strengthening, really going to progressive depth, as long as it's not contraindicated based on healing timelines from the ACL reconstruction. So that's really all I got. Just a quick little pearl on that with treating quadriceps tendinopathy. Again, going to treat it as you would with any other tendinopathy, with a progressive loading schedule. But with quadriceps tendinopathy, we want to change the treatment, making it distinct from patellar tendinopathy, and not just treating it like you would patellar tendinopathy, by switching from just adding load with squats initially to adding depth with squats to increase the load instead of the weight. So everyone, have a great weekend. I don't have any more courses scheduled for the year. I will be teaching with Virtual Ice here in the next month. So if you haven't checked out Virtual Ice, check that out. It's a great way to get a ton of information from all of us at the Institute for Clinical Excellence on a weekly basis. And hey, Addison, or Jess, really reasonable, I think. So have a great weekend, guys.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our Virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.